Good evening, everyone, and thank you for attending tonight's Research Tuesdays event. I'd like to start by acknowledging the Kaurna people, the original custodians of the Adelaide Plains and the land on which the University of Adelaide's campuses at North Terrace, Waite and Roseworthy are built. My name is Olivia Bellis and I'm a PhD candidate in the School of Biomedicine here at the University of Adelaide. I'll be your MC tonight as we hear from experts about how they're improving endometriosis care. Currently, pathways to diagnosis and treatment are challenging. Painful symptoms are often overlooked. Diagnostic tools can be costly and invasive, and the diagnostic process is lengthy and laborious. But tonight's speakers, Professor Louise Hull, Dr. Beck O'Hara and Dr. Jodie Avery are breaking down the barriers to accessible care. Please join me in welcoming them to the stage.
Thank you so much for inviting us to speak tonight. And I really appreciate that we've been able to talk about this research project that we've taken, that we've been working on for quite a wee while and have several different aspects that we're presenting tonight. The whole point of it is to improve endometriosis care. I'm very, very lucky to work with these two amazing people who are very dedicated to helping people with endometriosis, Dr. Beck O'Hara and Dr. Jodie Avery. And Beck has been involved in the online platform to help raise awareness and to reduce normalisation of pain, whereas Jodie's been working very much on our non-invasive diagnostic and using AI and images to help people get a diagnosis much earlier. My job is to introduce, and basically I want to talk about what endometriosis is. And endometriosis is where tissue similar to the endometrium grows outside the uterine cavity. A lot of people have this. This is a very common condition, about 1 in 9 women. So it's about 35,000 women in South Australia alone, and more than 190 million women worldwide have endometriosis. So it's something that is very common, but it's so poorly diagnosed and so poorly estimated that a lot of people don't know they've got it. When we look at what happens to people with endometriosis, often they've seen on average 6 doctors before they get a diagnosis. And it takes about 6.4 years in Australia and probably slightly longer in other countries. The condition itself can go on to cause complex pain. It can impact fertility and it can impact sexual function. And it can really have significant lifelong consequences that we think would be helped by getting a better diagnosis and better treatment earlier on. Additionally, there are significant socioeconomic consequences of this condition because once a month, young girls have to take time off school when their period pain is really severe. And so they miss out on their education and they find it hard to keep a job down. And it can really impact their training and their ability to function in life. And we really do need to look at a lot more about what research we can do to help people and how we can change that. In Australia, in 2019, Ernst Young did a big economic study on the cost to Australia, and it's about $7.4 billion. And a lot of that is time off or inability to function because of pain. So it's a significant condition. A lot of people say we don't know what causes it and we don't know why some people get it and some people don't. But what we do know is we're increasingly aware of some of the pathophysiology of endo. And what happens is that the tissue that's like endometrial tissue that's in the pelvic cavity, it responds to the menstrual hormones the same way the lining of the womb does. And when you get a period, that tissue breaks down. But unlike the lining of the womb that can leave your body, that tissue can't leave your body. And the only way you can get rid of those dead cells is to get your immune system to come in and take them away. So you get an inflammatory response and you get swelling, heat, dilated blood vessels and inflammation in the pelvis, and then that tissue repairs again in response to the hormones. And it goes through that cycle every month. And that can then create chronic pain. Now, we did a video, an animated video, to kind of show the way complex pain can develop if you have these repeated pain triggers from this tissue breaking down and responding. And this is actually on Endozone, which Beck's going to talk about. But I would like to show you this video that we made to explain things.
Endometriosis tissue grows in response to estrogen during the first half of the menstrual cycle and remains stable until you get your period. In people with endometriosis, during your period, endometriosis tissue breaks down and bleeds, similar to the lining of the uterus. Unlike the lining of the uterus, which leaves the body during your period, endometriosis tissue remains inside and it may trigger an inflammatory reaction. The immune system responds by releasing molecules which can cause irritation of the surrounding pelvic tissues, including the nerves. When this process is repeated, new blood vessels form, which helps endometriosis grow again. New nerves may become sensitive and scar tissue can develop. This can cause substantial period pain and bloating. These recurring episodes of pain may alter nerve centres in the spine and can cause back pain. Bladder pain, bowel pain and painful sex can be symptoms that the pelvic organs and tissues have become highly sensitive as a result of frequent pain. Sensitization can affect the pelvic floor muscles that contract and tighten. When this happens, people with endometriosis often experience stabbing or shooting pelvic pain, back pain, pain down the sides of the abdomen, or pain down into the thighs or legs. This pain can be disabling at times, preventing many people from moving or functioning. Ultimately, when nerves become sensitive, pain centres in the brain can get activated and central nerve sensitization may develop. As a result, people can experience tiredness, headaches, nausea and brain fog. Sometimes people may lose interest in activities they usually enjoy and can feel down or anxious. Although surgery removes endometriosis lesions, it doesn't resolve nerve sensitization. Endozone aims to provide people with endometriosis with information and tools that will help them manage their disease.
So the three main issues when we talk to community members are normalisation of pain. Many people have relations who have endo, or friends who have had period pain, or colleagues, or employers, or doctors who say, look, it's normal to get period pain. This is normal, why aren't you coping with it? And that's called normalisation. And actually people do have quite severe pain, and often people don't know they've got endo. So they think they're not responding well to their pain, where in actual fact people don't understand the kind of pain they have. The second thing is that it takes so long to get a diagnosis because people don't respond to their signalling that their pain is not normal. And we have ways of telling people about what's normal and not on Endozone. The last thing is, it's actually really hard to perform trials to find out what the best treatments are unless you've had surgery, because surgery has been the only way we've been able to diagnose it, and it's just not accessible to everyone. So it's in primary care, the pathways for treatment are not very well established because they've all been established in trials that have been done after people have surgery. And we want to today tell you some of the ways we're trying to change these three things to make things better for people with endo. And I'm going to hand over to Beck O'Hara, who was very integral in managing Endozone and putting it together and developing it.
Thanks, Louise. So Endozone is a co-created health informatics platform that's funded by the Australian government. Now, we co-created this platform with patients, their partners, parents, endometriosis associations, clinicians, researchers, and health informatics specialists from across Australia. We used this design thinking framework to really guide the co-creation process. And as part of that process, we ran focus groups, workshops, and community surveys to really understand the challenges of living with endometriosis, as well as to identify the priority areas that we should be focusing on with Endozone. So I just want to share with you some of those findings. So when we were running our focus groups, we asked participants to send in photos that represented what living with endometriosis looked like for them. And what's on the screen at the moment is just a selection of these images, and I've removed any that identified participants. Our focus groups also highlighted a number of challenges. So as Louise mentioned, that normalization of symptoms, which can occur at the individual level, amongst their friends and family, and healthcare providers in some instances. Our participants spoke of issues with medications, so having side effects, or their medications not quite managing their symptoms. And I guess the symptom that most people struggled with was pain. And so for some, that required them presenting to the emergency department for pain management. They told us it's still quite a taboo topic, not really discussed in the community. And the partners of the participants told us that they really didn't understand that much about endometriosis in the beginning. They spoke about pushing through their symptoms and just trying to pretend that everything was fine while they tried to do their daily activities, such as attend work or school. They wanted to know the implications for fertility or planning a family in the future, although they did tell us that this really needed to be managed sensitively with reference to the participants' actual concerns, intentions to have children, and be discussed at a suitable age. They spoke about an impact on physical activity. At times, they had trouble participating in sport, exercise, or recreational activities. For some, even walking was a problem. Work and school challenges were really around absenteeism, experiencing symptoms while they were in these locations, and not really having that support in those locations. They also needed sometimes to drop down to part-time work or reduce their study load. So after we ran the focus groups, we really wanted to work out what the community priorities were. So we ran a community survey and we asked them to select their most important priority area from a list that we generated through our focus groups and workshops. So we had 347 people participate, and you can see in the top box above me that the three most important priority areas were doctors' education and communication on endo, addressing normalization of pain, and pain management strategies. So this formed the foundation for Endozone. So we launched Endozone on the 31st of March 2022. And on the site, you'll find information for people with the condition, those that support them, and their clinicians. Since launching, we've had 73,000 visitors to the platform. And you can see that predominantly our user base is from Australia, but we are starting to see more of a global reach with US, UK, and New Zealand users starting to come on board. So I did want to just take you through some of the interactive features that we have on our platform. So as Louise mentioned, people in our focus groups really had a bit of trouble working out whether the period symptoms they were experiencing was normal or not. So we included a symptom checker, which was developed by Melissa Parker, called the PIPA tool. And they get interactive feedback as they complete the tool, suggesting that perhaps if they're scoring quite highly, that they should go see their doctor. After the symptom checker, we have the health report. And this was really designed to facilitate communication between the patient and the healthcare provider. So it allows them to prepare for their doctor's appointment by documenting symptoms, the treatments they've tried, their medical history, how effective those treatments were for them, and also their goal for the appointment. They can then download this and take it with them to the doctor. So it prints out like a nice one-page summary that makes it easier for the healthcare provider to get a good sense of what's happening for that person. Based on the information they put into this form, there's an algorithm that sits behind the platform, and it recommends strategies based on their symptom profile, as well as based on other people with a similar symptom profile and what they've found useful. So that gives them something that they can try while they're waiting for their doctor's appointment. If users want to track their symptoms over time or their health reports, they can save this documents in a free user account as well. So the information we generate from the health report gets stored in an aggregated community database. And the good thing about this is that we can learn about community trends from this information. We use this information to address any gaps that we have on Endozone. And we also use it to update our algorithms that recommend articles and help and advice to people. So we analysed some of this data and we pulled 5,668 reports. And you can see on the screen that the most common symptoms are period pain, fatigue, and reduced emotional well-being. We also asked people, how effective the strategies are and what's useful for them. So amongst these users, they mentioned that heat, pain medications, and resting and sleep were the most useful treatment options for them. So another thing that we learned from the focus groups was that people were struggling to manage their pain, and they wanted pain management strategies that they could do themselves. So in addition to the evidence-based information we have around symptoms, diagnosis, and treatments, we also included some self-management guides so that people can trial different strategies to manage their symptoms. These are interactive guides, so there's a lot of videos and audio files to help support someone trial these different strategies. So everything on the site has been approved by our clinical advisory group, so you know what you're reading is evidence-based and up-to-date. So on the screen are just a couple of examples of the self-management guides that we have. So the first one is about how to use a TENS machine. So a TENS machine is like a small little device that sends out electrical pulses that can help you manage pain. And on the other side, there's an audio file on how to relax your pelvic floor muscles. Among people with endo, sometimes these can be quite tight, and so learning to relax them can help with symptom management. So I'll hand over to Jodie now so she can tell you a little bit more about our Image Endo project.
Thanks, Beck. Okay, so I'm actually going to give some insight and information into about reducing diagnostic delay of endometriosis and what our Image Endo team are doing about it. And just to give you some idea, here are some current costs of endometriosis diagnosis and treatment in Australia. For laparoscopic surgery, it's about $5,000 to $8,000, and that's in the private system. If you're public, there's no cost, but of course there's up to a 2-year wait, and those waiting times are getting blown out all the time. For ultrasound, it's about $350 in Adelaide for a private ultrasound, and for MRI, it can be anything from $450 to $650. And of course, the costs can be a lot higher interstate. So there are many different clinical presentations and a really poor association between symptoms and the severity of endo. These contribute to difficulties in obtaining a reliable diagnosis based solely on symptoms or a physical exam. And according to the international guidelines, a visual inspection of the pelvis at laparoscopy has been considered the gold standard to obtain a diagnosis, but this is really changing. It can actually take 6.5 years to obtain a diagnosis, as we've said before, and in Australia, and that is blown out, of course, by the waiting lists for surgery, and if you don't have private health insurance, of course. So when GPs think that there's a possibility of endometriosis, women are usually sent to a gynaecologist, who often have only enough time to just decide to book patients in for surgery. But there are other options. Currently, surgery is held as the most accurate and often the only diagnostic test for endometriosis that is used in clinical practice. But surgery is associated with significant costs, as said before, the need for anaesthesia. It's an invasive procedure that carries a lot of risks, like bleeding, infection, damage to adjacent organs, and the big vessels, as well as the recovery time that is needed, so taking time off work and school. Actually, only 75% of visually diagnosed lesions are confirmed through pathology tests from surgery, and only a third of women who have a laparoscopy are found not to have endometriosis. So we know that our health system doesn't have the capacity to operate on the 11% of women that actually have endometriosis, particularly as this is deemed elective surgery. So using imaging is a great alternative with many benefits to reduce diagnostic delay. It's great for triaging women who don't necessarily want surgery and may like to look at other treatments. So ultrasonography and MRI can be really useful, mainly in diagnosing endometriosis-associated ovarian masses or deeply invasive lesions, with limited accuracy in superficial and the less severe forms of the disease. So I would like to highlight the research that we're doing around non-invasive diagnosis of endometriosis using imaging and artificial intelligence. Specifically, I'd like to talk about the diagnosis in primary care, as well as our solution, which is the Imagendo project. We want GPs to be able to order appropriate ultrasounds for endometriosis before women are sent to specialist gynecologists so that they can make the diagnosis and patient management can start with medication or physio before they get to surgery, and this will eliminate the diagnostic delay. Our vision is actually to develop a non-invasive diagnostic tool based on AI and imaging, which we now have a provisional patent for. We'll automate imaging quality assessment with an automated assessment of scan quality to check if scans have been undertaken correctly. And we'd also like to have a credentialing system for sonographers so that we know that they are trained in this type of scanning. We'd like a real-time educational feedback tool that sits inside the ultrasound machines to teach the sonographers how to undertake these types of scans properly. And we'd like also a regulation of Medicare imaging rebates for endometriosis so that practices are sufficiently compensated for these scans and encouraged to take these scans as well so that they are done properly. And finally, we want to have an online access to diagnosis so that women and doctors for anywhere in the world can upload their scans onto the Imagendo cloud. This will check if the scans fulfil the requirements for a specialist endometriosis scan for adequate diagnosis, and also the patients will receive the probability of a diagnosis of endometriosis from the Imagendo algorithm. We want to achieve a global reach with our international collaborators. So actually, many researchers and collaborators from all over the world have been reaching out to us to be part of our project. Recently, we actually surveyed 104 GPs in South Australia, or most of them were in South Australia, and only 5 of those GPs were actually male who answered the survey. 27% were from rural and remote areas. The diagnostic challenges for endo reported by GPs included the normalisation of period pain, as we spoke of before. There's a real under-recognition of the condition, there's a financial burden, and there's also a difficulty in confirming the diagnosis. In regard to the use of ultrasound, 73% of the GPs ordered ultrasounds to investigate the suspicion of endometriosis, with 42% that were specifically ordering an endometriosis transvaginal scan. GPs actually identified that there was a lack of quality bulk billing services due to limited numbers of providers with specialist endometriosis scans. And 74% didn't feel comfortable assessing the quality of a scan for endometriosis, with 61% saying they had preferred providers for endometriosis ultrasounds. The GP stated that they referred to providers that either specialised in women's ultrasound or were recommended by gynecologists or were bulk billing practices. And 58% of GPs agreed that having credentialed sonographers who they could trust for endometriosis would influence their choice of scan providers. Additionally, the GPs mentioned that highly specialised scans are associated with a significant financial cost for patients, and it's really unreasonable to expect patients to pay $200 out of pocket and travel very far for a highly specialised ultrasound. So internationally, being able to diagnose endo without surgery is a priority, and the medical societies and the colleges are really recognising this. In 2022, there were significant changes to the European Society for Reproductive Health Research, guiding guidelines for the diagnosis of endometriosis, with clinicians now being encouraged to use imaging. And the best modalities were transvaginal ultrasound, or MRI, and this was based on some Cochrane reviews that Professor Hull did, which our group is updating at the moment. However, we still need to be aware that a negative finding on imaging doesn't exclude endometriosis. So here is actually a demonstration of how an endometriosis transvaginal ultrasound differs from a normal pelvic ultrasound. These highly technical graphics were produced by the talented Dr. Matthew Leonardi, who's on our team, and he's an expert in transvaginal ultrasound for endometriosis, and he's known as a sonologist. Usually for a routine scan, the probe is placed in front of the cervix. However, this will not correctly show everything we need to see for endometriosis. If the probe is placed behind the cervix, then we will be able to check for endo in places like the pouch of Douglas, the bowel, and sometimes the ovaries, which hide behind other organs. And often when this type of scan is requested by a gynecologist, the specialists end up receiving a shorter version of a routine pelvic scan, which may not show any endometriosis. And often the patient pays for something that they don't actually receive. So it's really important to have the scan undertaken by a specialist sonographer trained in endometriosis transvaginal ultrasounds. So for our solution, we need to obtain data from quality transvaginal ultrasounds and MRI images. Ultrasound markers for endometriosis have been identified through a thing called the IDEA consensus, formulated by one of our other chief investigators, Professor George Condis, as well as other markers identified on MRI scans, which have been identified by another of our chief investigators, Adelaide's own Dr. Stephen Knox. Often these markers look at the same sign, but in a very different way on each modality. And on ultrasound, they can move about a bit. When these signs are combined, they can actually improve the accuracy of a diagnosis. And we are systematically using each of these markers to build our algorithm. And I'd like to show you how some of these signs can appear on a specialist transvaginal ultrasound. And this is what an endometriosis nodule occurring on the bowel looks like. Bowel endo is really common, and it's found in up to 37% of endometriosis cases diagnosed with laparoscopic surgery. And some of the symptoms of bowel endo really actually reflect irritable bowel syndrome as well. So often that gets mistakenly diagnosed as IBS instead of endo. So these symptoms include things like constipation, bloating or gas, pain in the pelvic area or lower back, pain during sex, infertility, and digestive or gastrointestinal pain. So if surgeons don't know about the occurrence of bowel endometriosis before surgery, then unless they have a colorectal surgeon ready during surgery, they may not be able to remove this endometriosis. This means that another later surgery with the right surgeons will have to be rescheduled. This is why using imaging for diagnosis prior to the laparoscopy is so important. This is another place where endometriosis occurs, the uterosacral ligaments. It's pretty much the most common involved location with a prevalence to 20 to 70%. And symptoms endo on the US cells include chronic pelvic pain, painful menstruation, and pain during intercourse. But this is actually a normal scan with no endometriosis. And you can see the clear white thick line with nice sharp edges. So contrast it with this scan. This is an example of another uterosacral ligament endometriosis nodule, and we can see how pushing with the ultrasound transducer at the top shows the sonographer where the endometriosis is. You can't see the clear white line anymore, but you can see an endometriosis lesion stuck on the uterosacral ligament where the arrow is, and the ligament's being pulled up into the nodule. And another test, called the jiggle test, can show superficial endometriosis lesions. They quite often say you can't see superficial on ultrasound, but we believe that you can. Because ultrasound machines and interpretation of images are getting so much better. Often it's thought that you can't see it, but with the right techniques and skills, the lesions can be seen. And we're finding that their skills are getting better and the technologies with ultrasound are improving. So MRIs are also getting better at picking up the lesions as well. This is a picture of an MRI showing a plaque behind the uterus in the pouch of Douglas. MRIs give a global view that show the tissue being pulled up into the lesions at the back of the uterus, obliterating the pouch of Douglas. An ovarian cyst can be a number of different conditions, not necessarily endometriosis. So it's really important to make sure we know what the pathology of these are. Is it endo or is it something else? So in these two pictures at the top, we can see an ovarian endometrioma, where the yellow arrow is. MRI can distinguish between different types of ovarian cysts. And when you change the MRI sequences, you can see lots of fluid in the endometrioma, which is actually old blood. And these contain lots of iron, which shows up bright white with the magnet of the MRI, as shown in these pictures. This similar technique can pick up smaller lesions as well, as you can see on the bottom slide, a picture. As long as the imaging slices are very fine, you can see the bright white superficial lesions that contain iron as well. So we're also getting better at this technology and more experienced in recognising the different types of lesions. So we know we can find better ways of diagnosing endometriosis, but we also need to do something about it. So currently we're taking the ImageEndo project, where we hypothesised that we could combine endometriosis ultrasounds and MRIs digitally using machine learning to improve the diagnostic sensitivity and specificity of imaging diagnosis of endometriosis. And we brought together the ImageEndo collaborative group of experts all over Australia and the world and obtained medical research future funding from the Commonwealth Government in 2021. And here are some examples of pouch of Douglas assessment using the sliding sign, using unpaired MRIs at the top and ultrasounds at the bottom. In the left pictures, there's no disease, and on the right we have endometriosis in the pouch of Douglas, which is behind the uterus. And here we can see this much better in the ultrasound at the bottom, where the organs are moving freely, which indicates no disease behind the uterus. The green areas on the MRI at the top indicate there are large pools of fluid behind the uterus. Compare this with the ultrasound image on the other side, where the organs aren't moving, which shows that the bowel cannot freely slide over the uterus, indicating endometriosis. And the red line at the top of the MRI picture indicates no space behind the uterus, showing a different sign of endometriosis. So we worked out that if we could use the very clear ultrasound signs to teach the MRIs to have a greater accuracy for the diagnosis of using AI. And in clinical practice, there are very few people that can diagnose endometriosis with one of these modalities, and very few that are proficient in both as well. So this table illustrates the area under the curve for the MRIs is not that high at 65%. And the area under the curve actually demonstrates the probability that you might have a diagnosis of endometriosis. However, we can pre-train the MRIs using AI techniques, increasing this probability up to 77%. And if we teach the model using the ultrasound data as well, the MRI can detect endo at a 90% accuracy. So we can use the two different imaging modalities to improve the accuracy of each of these modalities. And we can look at multiple signs to see if they can improve the accuracy of other signs. And we hope that people would be able to upload either an ultrasound or an MRI or both to the Imagendo cloud to get an accurate diagnosis. So this work was done by our amazing PhD candidate, Yuan, who is here tonight, and she formulated the algorithms for Imagendo. As you can see, there have been many iterations and combinations to combine not only the different sizes of endometriosis, but also the different diagnostic modalities we're using. And we've got some other members of our team here. Ali, who's working on ultrasounds for her PhD and the quality, and Misha, who's looking at accessibility, and Annie, who's looking at femtech and how it affects Imagendo. And also Rachel, who's doing a bit of a honours thesis in looking at quality of life in endometriosis. And I've got some flyers outside, so if anybody wants to take part in any of those projects, even if you don't have endo or you do have endo, we can use your help in either of the fields. So I now hand it over to Louise again, and she can talk about the benefits of Imagendo for clinical practice.
So we very much would hope that Imagendo will change people's lives, and that's why we've been working with Imagendo but also Endozone to actually make a big difference for people. But there's a lot that we need to look at. So our vision was to create a live, accurate online tool that democratizes the endometriosis diagnosis, empowering women to access timely, optimal care. We want this to be cloud-based, so a lot of people could use it, and we want to be able to use digital technology to analyse ultrasounds and MRI scans independently or in combination. We also want to support our general practitioners a lot more to be able to evaluate endometriosis risk, and we want to be able to automate the credentialing of sonographers and be able to inform people who are the people who are trained in this and can do this well. We want to be able to quality assess scans for people, because people have had 8-9 scans, none of which have done any scanning behind the cervix, and none of which have even looked for endo. They've only seen the uterus and the ovaries. And finally, we do want to improve the education and automate that so that people who are scanning can get prompts to scan in the right places and to improve. Finally, we want to get a faster and more accurate diagnosis so that patients can get the treatment they need much quicker. We think there will be significant cost savings, mainly because if we can use scans, it's much cheaper than surgery to get a diagnosis. It will also enable us to intervene a lot more quickly, and hopefully that will reduce the progression of complex pain symptoms and increase people's ability to be staying in school, to be able to do sport and to be able to work. And then also we hope that having that diagnosis will help them access the healthcare they need. And we do have chronic care plans for endometriosis. We have ways that we can help the GPs access care once people have that diagnosis. And you're on a level playing field with a health professional if everyone in the room knows that endometriosis is present. You can ask for things in a way that you can't if you don't have a diagnosis. For fertility, we can support people in terms of egg freezing, because endometriosis is associated with slightly lower egg numbers, and it's useful. You can protect yourself if you know about it. The other thing is we can actually start doing clinical trials of drugs and methods of treatment in primary care, so that people who haven't had surgery can actually have an evidence base for the treatments they receive by their GPs if they were having to wait a long time to get surgery, or if they actually don't want surgery but want different techniques. And we think this will optimize health pathways. We do look at helping with advocacy as well, and we now have specialist endometriosis clinics that this government has set up. There are 22 of them across the country, and we're working with some of the GPs in these clinics to try and help them access things that they really need to look after their own patients well. We have been involved in the inquiry in South Australia on endometriosis, as well as the National Action Plan that was a couple of years ago under the Health Minister then, Greg Hunt. And we continue to say what our community has been saying to us, which is this is an area that's been very underfunded and poorly investigated, and we need better information and better knowledge. We are also involved in developing new pharmaceuticals, and I have a group of 4 very dedicated ONG specialists who look at running new drug trials out of Park at the Royal Adelaide Hospital. And we were involved in the Relagolix trial, which is now known as Reiku. And Reiku's the first new endometriosis drug in 13 years that's come onto the Australian market. So that has had a significant change, and it's only been available in the last 6 months or so. And we're now looking at another drug trial for a device which has been formulated by Susan Evans, which looks at period suppression and pain management. And we've done the first in human trial of that, and we just took the first phase 1 devices out literally this week, and we're about to go on to phase 2. So there's new things on the horizon for people that can be used in primary care. In terms of our group, we do look at new pharmaceuticals, as I've just said, artificial intelligence diagnostics. We do a lot of work with adolescents to try and help them. We do have some pain management trials with Adelaide University. That name change happened about a couple of weeks ago. We are looking at the microbiome, targeted fertility treatments, as well as digital health informatics. So there's a lot going on, and a lot of people are coming to us with great ideas. This is our group, and I'm incredibly proud of them. A lot of them are sitting in the first couple of rows over here, and a lot of people have a real dedication to helping people with this condition and a real understanding of how difficult it is for some people when you do have endo. And we were fortunate enough to win the Eureka Prize for Innovation in Technology in 2023. And our amazing PhDs all keep winning prizes every time they give a presentation. So we're very fortunate with the skills we've got in the team. These are QR codes if you want to know anything. But we have quite a lot of digital online presence. And a lot of people come to us wanting to donate scans or wanting to donate their time or wanting to be part of our trials. And if you do want to do that, please feel free to contact us. And thank you very much for letting us tell you about this. We really appreciate it.
Thank you so much. That was a really great presentation. Now we are going to open up questions from the audience. So for those online, please submit via the Q&A section of the webinar. Our speakers won't be answering any personal medical questions, but general questions about endometriosis are welcomed. But I might start with a prior submitted question. How can chronic pain and fatigue symptoms be managed?
Chronic pain and fatigue. Chronic pain is very complex, so often it involves lots of different systems. It can be back pain, it can be organ symptoms like bladder symptoms or bowel symptoms or painful sex. It can be sharp shooting pain, that tends to be muscular pain, and it can be headaches and fatigue. So there's a lot of different systems, and each different pain needs to be approached in a different way. So for example, if you have a pelvic floor muscle spasm, one of the best treatments is actually physiotherapy. you need to be able to stretch the muscles, and there are lots of different stretching techniques and ways of relaxing the muscle tone. And that is actually physical therapy. So surgery won't help. Surgery doesn't do anything to the muscles. Your surgical result will be better if you've had muscular pain that's been treated, and often that's things like physiotherapy. For things like central pain, so fatigue, headaches, there are some pharmaceuticals that can help, but a lot of people find mindfulness, psychological support, things like being able to have enough time to rest properly, to be able to plan well and not overwhelm themselves with commitments makes a big difference. So there are lots of different other ways of looking at that. Other things are things like heat and TENS machines. So there's a lot of different complex pain treatments. Ideally, we'd like to prevent it by reducing pain triggers. So a lot of people would also look at period suppression so that you don't get a pain trigger every single month. And that tends to be either using hormones like pills or devices like Mirena coils, or something where we can suppress a period and reduce that cyclical inflammation to try and prevent it.
Great, thank you. Was there any questions from the audience? Yep, just over here. We'll just get a microphone to you.
Hi, my name's Dr. Cindy Millington, and I just want to applaud you for what you're doing. I have been an endometrial person suffering with it for years, and I feel like I've been looking at my life with your slides. So I had it for it was quite a long time before I was diagnosed, and I had pain. So when you were talking about the pain relief, one of the things that happened with me was I was diagnosed with a laparoscopy when I went through IVF, and it was stage 4, and I also had a chocolate cyst. But I actually really got treatment when I went to the endometriosis clinic on the Parade, and you mentioned Dr. Susan Evans, and she picked it up, and I actually had ovarian cancer. So I had to have a hysterectomy and oophorectomy. But what I wanted to say was the pain relief caused, I was told to take Ponstan, which is mefenamic acid, which is not supposed to take on an empty stomach, and I didn't. But I actually developed a huge ulcer, and so had low iron and low hemoglobin. So there's things like that that you don't get told. So to me, I think you've really touched on the key things. Getting an accurate diagnosis and normalisation of the pain was the issue that I had to deal with everywhere. I was known, it was a female doctor who was a gastroenterologist who said to me, I think you should go and see my friend on the Parade who is running an endometriosis clinic, because I think there's something else going on here besides your ulcer. So if it wasn't for her quick thinking, I might not be here, because that doctor picked it up on the transvaginal ultrasound and said you need to have surgery. So I think the diagnosis can be, getting an early diagnosis can be pivotal, because you don't know how advanced the endometriosis is when you actually get it diagnosed if you've been living with it for a long time. So I think that's the key thing, what you're talking about with the ultrasound. But it's also, how do you educate the primary healthcare people, because I think that is another key factor.
Thank you for sharing your experience. We are working quite extensively with the general practitioners because, as you mentioned, they're kind of frontline. When people present, they're usually presenting firstly to their GP. So some of the projects that we've got going on at the moment with Endozone is expanding our clinical resources so that when someone's sitting in front of a GP, even if they're not specialising in women's health, they know that they can go to Endozone, quickly pull up what they need and have a conversation and start that treatment and management process with them. So we're hoping in the future that our clinical resource offerings through Endozone and the interactive tools that we're building at the moment will help
as you said, educate those GPs as well to help manage that process for people.
Yep, there's just a question over here.
Hello, my name is Layla. I'm monitoring the online questions, and there were a lot, but I was just hoping that I could perhaps ask three of you in a row, if that's all right, and that's quick. First of all, this is from an anonymous guest. I've been trying to get diagnosed for 10 years now. The TV ultrasound is something I'm always denied due to the issue that virgins are not able to undergo this process. How do we challenge this?
Well, in some cases it might not be appropriate, but if you speak to some of the sonographers here, they will say that if the young girls are mature enough to have them, then they should be able to have them if they want them. But Louise might be able to talk about the policy in that area a bit more.
Actually, I might just hand this to Ali Deslandis, who's actually, Alice Deslandis is one of the best sonographers in Adelaide at the moment. She's doing a PhD with us, but she does a lot of sonography scanning. And this is a question that comes up a lot of the time. And she'll tell you actually what it's like to be a sonographer when you are with someone who hasn't necessarily, is a virgin, and what sort of things you would do to make people feel comfortable if they were having a scan.
Hi, yeah, so first and foremost, there really isn't any reason that somebody should be denied access to medical care based on their sexual history. It's a medical procedure, it's not a sexual test, and the concept of virginity is a social construct, so whether or not somebody's had penetrative sex really doesn't have anything to do with it. What does have something to do with it is if somebody is capable of providing informed consent, understands what they're doing, and feels comfortable going ahead. So I do really sympathise with the person online there, because that's something that we do unfortunately see quite a lot happening, and it is really frustrating when you're met with a barrier to access which really you shouldn't be met with. I think there certainly are providers that will do that for you. It's certainly a bit of a changing time. I've been working with some researchers over at UniSA where we've just done some studies on this particular question and why sonographers are doing this. And really it kind of comes down to just this is the way we've always done it. Unfortunately, it's a lot of paternalism in medicine, which I'm sure a lot of you have probably come up against. And it will be something that does change in the future. In terms of how you can feel comfortable having a transvaginal scan, as Louise sort of asked, I think it's really important that you are quite open and honest with the people doing your scans, seek out providers that you're going to feel comfortable with, and have honest conversations. If something doesn't feel right when you're in there, make sure that you speak up and say stop, and make sure that you feel that the provider is somebody that you trust and can work with you. It is an intimate test, but it's certainly something that can be very, very beneficial, and in the most part people will tolerate it quite well. And so I think that as long as there's a good two-way communication between your provider and yourself, then there's no reason you shouldn't be able to have it done.
There are some people who would find it very uncomfortable, yeah. But one of the other things, and that's partly why Imagendo is looking at MRIs on their own. Certainly for young people, we would consider an MRI, which is not invasive, as a first step, and there would be some people who would just be traumatised by a transvaginal scan and would feel uncomfortable, but you could look at doing an MRI. And in November last year, 2022, the government did bring in a subsidy for MRIs, but a gynaecologist, not unfortunately primary care providers, have to order it. So you would need a referral to a gynaecologist to get an MRI scan, but that is an alternative. And you can do transrectal scanning as well, which I'm not quite sure if it's which is worse, but but that is another option. Yeah. It's not commonly used.
Thank you so much for that. In the interest of time, I'll actually just ask one more question and then give it back to the crowd. Is there research around potential treatments for removal of organs or areas that people who do not want children can access?
There is, but it's a very tricky situation because, particularly for young people, doing something that would remove their fertility at a young age where they may change their mind is always going to be tricky for gynecologists. So it involves a long process, a lot of thinking, a lot of the alternatives that can be used that are non-permanent. So, for example, things like the Mirena or period suppression in other ways would be considered first for young people. You would need almost certainly more than one gynecologist make that call, just so that it's been thoroughly consented for and really well informed. But there is some research around that. It's not something that people don't want to take autonomy away from people to have children at some point in their lives. So they tend to try non-permanent things first.
I just had a question about regarding the rising numbers of endometriosis diagnosis and if there's any work being done to find the causes of it or anything in terms of primary preventative care?
It's tricky. There's a lot of different thoughts about causation, and so they've looked at genetic causes, and there's a very small genetic component, but it doesn't account for the prevalence of it, so it's only very small. We think there are probably environmental factors, things like dioxins that act as estrogen, similar to estrogen, and make lesions grow. We think the more periods you have, or if you have an obstruction, if there's been a blockage in the reproductive system, you're more likely to get endo. Probably if your immune system doesn't work, and it might be in 1 month, not necessarily on every month. If you've got something where your immune cells aren't clearing your cells well enough, you may develop it. So it's a very multifactorial thought behind the cause, and 3 or 4 factors that might affect one person might not affect another, and you might not get it. So there's sort of no clear way of figuring that out. We do know people are having their children later, so people are having a lot more periods in their life. We do know that we're getting better at diagnosis, and just the number of people that have actually been able to talk about endometriosis publicly has really raised the awareness. So people may have had it a lot but couldn't talk about it, in a way that our society's really matured in talking about reproduction and menstrual health. And so I think there are so many different reasons that we now know about endo, that also means people are exploring whether that's something they've got, where they might have been told that it was normal before and just are not taken it any further. So I think there's so many different aspects to that. Do you want to comment on that?
I think another thing is the increased awareness, as Louise mentioned. More people are seeking out a diagnosis as well. So, when I was younger, perhaps it wasn't that well known, and it was normalised. Period pain was normalised. So now we have things like the Menstrual Schools program, which Susan Evans actually created in South Australia, that's going around to all the schools. They're talking to the girls and the boys about this kind of thing, telling the kids what's normal, what's not normal. People are getting aware of these things, and people are being proactive and going to the doctor and saying, hey, I think there's something wrong here. It's not normal. The pain that I have is not normal. Is there anything I can do about it? What do you think it is? So that could be another reason why there are escalating cases of endo around as well at the moment.
Thank you.
So we'll have to wrap up question time now, unfortunately, but I'd just like to finish by thanking tonight's wonderful speakers, Professor Louise Hull, Dr. Beck O'Hara and Dr. Jodie Avery. And thank you to you, our audience, for viewing and for your questions and comments. Be sure to sign up to our mailing list and receive the latest information about Research Tuesday's related news. Thank you for joining us, and we hope to see you next time. Good night.